Okay, I think in terms of attendees, we are at a stable number now. So good afternoon, and thank you very much to all of you who have taken the time out of the busy schedule to be with us online at this event about liver cancer. The title of our event is Liver Cancer, No Patient Left Behind, Optimizing a European Response. And we are very happy that we have a very European panel and also European audience. And I hope we're going to have interesting discussions and fruitful insights. First, I would like to start with some housekeeping rules. Next slide, please. Well, in terms of, so you will see that your chat function should be disabled. You will be able to have a question and answers. Also, your audio and your video are disabled, and this session is being recorded. After this event, you will receive a link by email to the recording so you can see us again and listen to the insights at your leisure. So that would be it. Next slide, please. Instead of in terms of the agenda, we're going to have a welcome by our chair, Lieve, and then we're going to have a first session about optimizing knowledge, followed by a second session about optimizing prevention. So without any further delay, I would like to invite Lieve Wierwing, our chair of the DICE board, a former MEP and a cancer survivor herself, to welcome you all.
Thank you, Alexandra. Good afternoon. My name is Lieve Wierwing. Like already was said, I'm a former cancer patient and a former member of the European Parliament and the current chair of Digestive Cancers Europe. It's my pleasure to open this meeting and a privilege to speak on behalf of the organization behind this meeting. Digestive Cancers, DICE, and European Liver Patients Association, ELPA, are two European patient advocacy organizations who have joined forces to improve the outcomes and quality of life for liver cancer patients across Europe. First, DICE is an umbrella organization of many national members from across Europe that passionately advocates for the European digestive cancer patient community. And ELPA has made it their mission to promote the interests of people with liver disease across Europe. It is important that the mission and activities of patient advocacy organizations like DICE and ELPA are recognized, and that we all work jointly so see fewer people suffering from liver cancer across Europe. Additionally, we are grateful for the support of the two most influential medical associations in the field of liver cancer research, the International Liver Cancer Association and the European Association for the Study of the Liver. As a colorectal cancer survivor, I understand and sympathize with the physical challenges of the disease. I am one of the lucky ones who benefited from the system. However, this is not the case for many European patients with digestive cancers, especially liver cancer. Liver cancer continues to be an increasing problem. It now ranks as the 7th leading cause of cancer-related deaths in Europe, with 90,000 newly diagnosed citizens and approximately 80,000 citizens who sadly pass away from this disease every year. Unlike colorectal cancer, for which there are established early detection programs available, as well as treatment pathways that provide patients with several lines of treatment, liver cancer appears as a neglected, heavy burden. As a former member of the European Parliament, I understand that there is still a lot left to be done to ensure that all cancer patients have access to the best treatment and care, and that no patient is left behind. It is our hope that with this event and future Digestive Cancer Europe collaborative efforts, we will amplify the discussion towards real action in improving, first of all, early and better detection, second of all, treatment options and accessibility, and finally, overall care for all liver cancer patients across Europe. Once again, thank you for joining, and I look forward to an impactful event. Thank you.
Thank you very much. And now we're going to move on to our first session, which is optimizing knowledge. The aim of the session for us is to look at the funding gaps, look at the research gap, and also show how important going forward for us as patient organizations is to secure a right amount of funding from the European Commission, from the programs, and to move forward. So I would like to welcome now Professor Sangro, who is a hepatologist, professor at University of Navarra in Spain, and he's also a leader of the ILCA patient advocacy program. Professor Sangro, you can share your screen now.
Thank you very much. I'd like first to, on behalf of ILCA and the global liver cancer patient community, thank both DICE and ELPA for hosting this event that I believe is truly, truly important for moving things forward to make not only access to care, but also prevention and early detection a goal that can be fulfilled in coming years in better ways in the European Union and in Europe as a whole. Let me share my screen. And I would like to first provide you some figures about what really liver cancer means. It is estimated worldwide that in 2020, almost 1 million human beings were diagnosed with liver cancer. And unfortunately, the figures of patients who died from liver cancer are not that far away from those that were diagnosed, meaning that this cancer has a quite high mortality. And we will come back to this later. But it's even more compelling for us today to realize that the estimates are that if we don't change things, if things keep going as they are now, in only 20 years, we will have a 55% increase in both incidence and mortality, making almost 1.5 million patients having this deadly disease by that time. So this is truly a major health problem worldwide, and it is in Europe, as it has been said a few minutes ago, with almost 100,000 people developing the disease in Europe. There are wide differences in the incidence, but as you can see, even within the European continent, there are differences with a higher number of patients developing the disease in southern states for reasons that could be easily understood in a few minutes. But altogether, Europe stands as an intermediate incidence area in terms of developing liver cancer. This is also a reason why attention has to be put in this disease as soon as possible. That may appear to be a busy slide is not so. What the slide is showing is the 5-year relative survival. So if you pay attention to the far left, you can see that for patients with testicular cancer, 90% of them are alive 5 years after they are diagnosed with this cancer. What happens with liver cancer? It's far at the right end. Only pancreatic cancer, among those cancers that are frequent in our environment, has a higher mortality. So there is a lot of things that we can and should do to change these incidence and mortality, because liver cancer is very rarely an hereditary disease. It's because of our environment, of the things we do, the places we live in, that any of us, our workmates, our neighbors, our relatives, and even ourselves can at any time point develop liver cancer. And it is even more important when we recognize that this is a stigmatized cancer, and that for reasons that will be discussed later, people is frightened not only by the disease, but by the burden of stigma that the disease carries with it. Why the liver cancer is so such a dreadful disease? because the liver itself is an important organ in the human body. It's single, it's essential for life, and it's homely. Single means that as contrary to lungs or kidneys, where if you suffer from cancer, you can remove the entire organ. This cannot be done in liver cancer. It is essential for life. Pancreas or the stomach are also single organs, but we can live without them, and we cannot live at all with the liver, which is the big factory that produces all the elements that all the organs need to survive. And it's homely, is a friendly place for all kinds of cells to live in. And this is one of the reasons why liver cancer growth inside the liver leads to liver cancer function deterioration, leading to problems and eventually to death. And we know, this session is about knowledge, we know a lot about how does and what causes liver cancer and how does liver cancer develop. It is usually the result of chronic inflammation in the liver, leading to progressive fibrosis of the organ, and at the end, the development in many cases of cirrhosis. This is a continuum, but once a patient has developed cirrhosis, the chances that he or she may develop liver cancer at that stage is around 3% per year. Now realize that most of the liver diseases start at an early age. So you have a lot of years to develop liver cancer if you consider these 3% per year incidence of liver cancer in cirrhotic patients. And what is more important is that this journey from which we know a lot, but we also know lots of things, this journey is a silent one. The liver is a silent organ with a lot of extra function we know called the functional reserve. And it's only when the tumors are very large or has spread outside the liver that symptoms usually develop. A time where it's too late to make cure and a realistic hope for patients that are diagnosed. What are the main causes? Of course, chronic viral infections, but also alcohol abuse, other liver diseases, and now increasingly, the metabolic syndrome with the pandemic of metabolic syndrome that we are suffering in Western countries, including Europe. Some of the causes are in red, in green, and this is because these causes are largely preventable. We can prevent chronic viral infections and treat them adequately. We can prevent and treat alcohol abuse. We can prevent and treat the metabolic syndrome. So the prevention is absolutely a must in terms of reducing the chances of patients dying from liver cancer. But there are other ways that we could take advantage of our knowledge of how liver cancer develops, grows, and ultimately invades the liver or other organs to produce death. And this is by focusing on opportunities for early intervention, because it takes time for a tumor to grow and make the patient be symptomatic and eventually kill the patient. If you just consider the time from the moment when the cancer starts, one cell becoming abnormal, to the time when the cancer is detectable, it usually takes months or years, because in the smallest detectable cancer, there are more than 100 million cells. So there is a place before the symptoms appear, after the disease is detectable, where cancer may be detected in a phase where it can more easily be cured. This is what we call the screening window. And what is important is that there are, in other tumors, we now have tools to magnify and widen the screening window so that we can even detect cancer cells before they are more easily detectable by the available methods. This screening window is particularly important in terms of reducing incidence but more importantly, mortality, because it's there where one can identify patients at early stages and provide them with curative therapies. Today, we have methods that are largely inefficient and expensive. They basically consist in doing liver ultrasound examinations for patients at risk, patients with cirrhosis or advanced fibrosis. The knowledge that we have, but more importantly, the things we ignore about cancer at this stage prevent us for developing better tools for screening. And this is a truly unmet need that European countries with the advanced technologies that we are able to use should pay attention to in terms of extensive research. Because we know that screening is important in reducing mortality. You can see in this slide the survival over 5 years of patients in 3 different settings, in 3 different continents. You can see in the bottom, patients in China having the worst of these 3 groups, the worst survival at 5 years. Then Europe is in the middle, and you can see how the mortality rates at 5 years in Japan is much, much lower. And why is that? That is because Japan has the only national screening program in the world. This is the demonstration that investing in screening programs, and even more, investing in research into providing better tools for screening, turns into reducing mortality. And this is truly a place where the research funding efforts has to be placed in the coming years. I will stop here by saying that together with patient associations like DICE and ELPA, together with other scientific societies like EASL and others around the world, because this is a truly global health problem, if we invest our minds and our money in doing good research and translating this research into patient-focused activities, I'm sure we will be able to reduce the burden of disease and the burden of mortality of liver cancer. Thank you.
Thank you very much. I think especially your closing remarks are really, really to the point. Now, without any further delay, I would like to invite Professor De Kervel, who will also have a short presentation for us. He's an oncologist and professor at KU Leuven here in Belgium. And just to remind everyone, if you would like to ask a question to any of the panelists, please write it in the question and answer section, also indicating which panelist would you like the question to be answered by. And we will try to answer all questions at the end of the session. So the floor is yours now.
Hi, good afternoon. Can you hear me? Okay, good afternoon. Thank you very much for the invitation to speak about the progress that we made in the treatment of HCC over the last years. Let me just start by saying that, and this is a very, I think, nice way to go on with Dr. Tsandro's talk. It's a very complex disease to treat, HCC. If I treat other patients with GI cancers, it's of course also complex because we have to take into account the tumor burden, the tumor stage, the extent of the tumor, and then also the patient with the tumor, with the performance status of the patient, and also the expectations of the patient. So this is already quite complex. But then in liver cancer specifically, we are adding a 3rd layer to that, and that is of course the liver. And the liver is sometimes, often, in a diseased state, and we have to take this into account when allocating a certain treatment to a certain patient with liver cancer. And this is really well reflected in, for example, the most used algorithm to treat patients with liver cancer. Of course, please do not mind the details, but you can see the complexity which we are working with, factors that take into account the patient status, factors that are taken into account the tumor stage, and also the liver function are all incorporated in very complex treatment algorithms that we use on day-to-day basis to allocate a certain treatment to a certain patient. And if you just compare this very complex algorithm to the algorithm of, for example, 20 years ago from the same group from Barcelona, then you can see that we added a lot of complexity to this algorithm with new treatment options, but also with more selecting a better selection of treatment options for certain patients. This is in fact the three topics that I wanted to discuss in this 5 to 7 minutes where we made improvements. Of course, there are other fields where we made improvements, but I think these are the three most important. And the first one is that we are better now than 10 years ago, 15 years ago in selecting treatments for specific patients. Maybe not really if we look at the left side of this algorithm where the early diseases, there we offer treatments with curative intent to patients with liver cancer. If the lesions are small, we can resect them, we can ablate them. Patients are eligible sometimes for liver transplantation. Also not really at the right side of the spectrum, where we know that, for example, if the disease has left the liver, this is a really good place for systemic treatments, but more in the middle. In the middle, we have a very heterogeneous group of patients, and because, of course, you can think of yourself of different situations with different kind of nodules, bigger nodules, smaller nodules, and it was always a bit the question which treatment is best for such patients. And it's not just one treatment. In the past, we used a lot of embolization techniques in these patients, so chemoembolization and later also radioembolization. But we have learned over the past years that some of these patients in this middle group are still eligible for liver transplantation. Our criteria to choose for liver transplantation were maybe a little bit too strict in the beginning. And we have learned that by opening that up to bigger lesions, to more extensive liver involvement, still not, of course, too extensive, that we can still offer these patients liver transplantation. And of course, this is a very elegant solution, which also treats the underlying liver disease, not only the cancer. But of course, this remains an option for a limited number of patients, also because we lack enough liver grafts. So then, of course, a lot of patients in this intermediate stage, they undergo still with good reasons embolization, but also the rise or the emergence of new systemic treatments over the last years is something that made us think of systemic treatments more early. Now we have more potent drugs, while 10 years ago we had a limited number of options, and we use these options more like as a last resort for our patients. And this has changed. We now think more early about systemic treatment, and this is because we have better options, better potent alternatives. And this brings me to my second point in terms of progress that we have made, more potent systemic agents. And I look specifically, of course, to the field of immune checkpoint inhibitors, immunotherapy, which of course has changed the paradigm in a lot of solid tumor types and also in liver cancer. As you know, these antibodies, they will reinvigorate the anti-tumoral immune system. They will tell to the T cells, the immune cells, to recognize cancer cells as being something to attack. And then, of course, this leads to clinical responses. Unfortunately, if we use these new treatments just on their own as a monotherapy, we will only see a benefit, a true benefit, in about 15 to 20 patients. And this is quite low. And we had some failures in terms of large clinical trials in that area just because of that, because the number of patients that benefit is too low. And we have learned that if we do this, if we use immunotherapy, we can better combine this with an agent that also manipulates the blood vessel growth in the tumor, so anti-angiogenic agents we already use for many years in other solid tumor types. And by combining those those blood vessel manipulators together with immunotherapy, we now have very nice results. And if we see new trials coming in the field of liver cancer, we see that with systemic agents, we are now able to say to the patient, well, on average, we see now an overall survival of about 20 months, which is much better than, for example, 10 years ago. So really not a perfect situation, but already a lot of progress has been made. The third and last point that I wanted to make is that we have learned, again, HCC treatment is complex. requires expertise. It is not something that can be done in one small local hospital without being part of a network where all options, including, for example, liver transplantation, are available. And this is something that we learned over the last years. And certainly also with the pandemic, we had more new technical possibilities to come together and discuss cases, also while not being physically together. And this creates huge opportunities now to combine expertise and to offer really all options, the best options to single patients. And with this, I thank you very much for your attention, and I welcome the discussion that we will have.
Okay, thank you very much for your presentation. I think for the matter of time, to make sure we have enough time for everyone, we're going to move on now to Professor Jepsen, who's a hepatologist at Aarhus University, Denmark, and a member of EASL Policy and Public Health Committee, which is a very interesting combination to have the two together. So please, you are welcome to share your screen now.
All right, thank you very much. I am sharing my screen now. Can you see it?
Not, yes.
Perfectly.
All right, so really the topic is whether we need a European registry for primary liver cancer. And of course, I think the answer is yes. But thank you very much for the kind introduction. I am Peter Jepsen, a hepatologist working at Aarhus University Hospital in Aarhus, Denmark. And I'd also like to thank the organizer for giving me this opportunity to present my public health interest in this important question. So, as we've heard in the talk from Professor Sangro, most patients with liver cancer have liver cirrhosis. And as you've heard in the two previous talks, there are several options for reducing mortality from liver cancer. One is that we can prevent liver cirrhosis from developing altogether. And then we can be better at screening our patients with liver cirrhosis for liver cancer. And as you heard in the previous talk, we are already getting better at treating those who have liver cancer. But really, the topic of my talk is dissemination of best practices. How do we ensure that no patient is left behind? So our goal is that every patient with liver cancer receives the best possible treatment. But as you also heard in the previous talk, there is something peculiar about liver cancer because the best treatment depends not only on the tumor and on the patient's performance status, but also very much on the severity of the underlying liver cirrhosis. And that's a very special feature of liver cancer. Now, I believe that we really need to collect data across Europe to ensure that all our patients receive the same high quality of care. And there are additional benefits to that. First, there is transparency. I mean, knowing what goes on where is very important. And also, this is a way to ensure that we can have more and we can have better research. There are, in fact, already some European registries that are important and well-functioning. For instance, the European Cancer Information System provides up-to-date data on the cancer burden across Europe, including liver cancer. See, for instance, this map of liver cancer incidence is in 2020, and you will see that it looks very similar to the one presented by Professor Sangro in the first talk. There is also a European Cancer Inequalities Registry, which is really a flagship initiative of Europe's Beating Cancer Plan. It aims to identify inequalities due to age, sex, socioeconomic factors, and urban versus rural areas. And then it is meant to be used to guide investment and interventions at the European, national, and regional levels. So here, for instance, is some data from that registry shows the frequency of alcohol consumption by country and educational attainment. Now, there's still nothing specific to liver cancer in this registry. And you can see this is the kind of information that's collected. It's mostly prevention and then also early detection and some screening efforts. And this registry is currently being updated with data relating to gastric cancer and prostate cancer and lung cancer. And I very much hope that in the future, and the not too distant future, it will also provide some information specifically related to liver cancer, but we're not there yet. There are still very many ongoing initiatives across Europe. So the EU have initiatives related to Horizon Europe mission on cancer and also to Europe's Beating Cancer plan. And there is the current implementation plan, which is from September 2021. It describes some new infrastructures that are already in place and some that will hopefully be in place in the near future. Much of it is included in the EU strategy from 2020 called Shaping Europe's Digital Future. And it's all sort of based on the European Health Data Space, which is a technical and legal framework to ensure the secure exchange of health data across the European Union. And hopefully by next year, we will also have the uncan.eu platform, which aims to combine research, patient health, and any other data at what is called an unprecedented scale. And the new understanding that we will gain through this platform from the analysis of wealth of data could be applied to other diseases than cancer. So really, I mean, this is a very promising platform. So the mission on cancer from the EU aims to improve existing policies and to help update and expand cancer screening guidelines. And it also aims to ensure equitable access across 4 objectives. One is understanding cancer. The second is prevention, including screening and early detection. The third is diagnosis and treatment. And then the fourth is quality of life. So within that objective, the aim is to collect and analyze data on today's unmet needs of cancer patients and survivors, including setting up the European Cancer Patient Digital Center. Now, it's in fact a question of many European cancer patient digital centers, one for each country, and then these national centers are combined in a network. And really, these centers are supposed to offer and to provide data from and to the patients, their families, their caregivers, and health professionals more broadly, and researchers to really empower patients and survivors to participate in research and to get in touch with other people across Europe who are in a similar position. So the way they say it themselves is that this is meant to be a network of patient-controlled health data infrastructures that enable the voluntary exchange of patients' and survivors' health care data. So, and there's been a recent call under the Horizon Europe, but unfortunately, there were 0 proposals submitted to establishing a European Cancer Patient Digital Center. And as you can see, it's now a month since that deadline was passed. So, I mean, this is really something that we need collectively to work towards establishing. But in summary, I would like to highlight that there are, in fact, good, well-functioning existing platforms like the European Cancer Information System and the European Cancer Inequalities Registry. And there are still very many, very strong initiatives from the European Union under the Horizon Europe and European Beating Cancer Plan banners. The goals are to reduce inequalities and to promote best practices and patient involvement. For liver cancer specifically, we need additional information than we do for many other cancers because of the close ties with cirrhosis. We need information on cirrhosis too. The European Union ensures the legal and technical frameworks. EASL and other professional organizations like ILCA know what information to collect, and EASL in particular also supports the establishment of European registries. And it's important that patient organizations and advocacy groups push towards the establishment of a European liver cancer registry. So let us remind ourselves that our goal is that all Europeans who have liver cancer or are at high risk of getting liver cancer receive the same high quality healthcare. Thank you.
Thank you very much. I think we, especially as a patient organization, take your last bullet point for pushing for those registries. We take note of that, that's on our to-do list. And now, as a patient organization, I would like to welcome Zorana, who's a very long time standing patient advocate and the CEO of Digestive Cancers Europe. And she can tell us how we can push for things like this and other burning issues.
Thank you, Ola. Hello, everybody. It is a pleasure to welcome you all here in front of DICE, to this meeting that is organized as part of the Liver Cancer Awareness Month. Aside from running the awareness campaigns during October, we feel it's really important to spark discussions that highlight liver cancer as an increasing health issue. From Professor Sangro, you have seen the data, and we now recognize that this is an issue that we cannot ignore, and we have to put it high on the agenda of the policymakers. Otherwise, we will witness the increasing burden of liver cancer in the years to come. So as DICE's CEO, I will just give brief overview from the patient perspective and from the perspective of our national member organizations coming from across Europe. As you have heard from Professor Sangro, Professor Deckerville, and Professor Jepsen, liver cancer is an increasing problem. And yes, there is hope, but we still feel that more research needs to be done in order to address the increasing unmet medical needs that our community is facing every day. And with this in mind, in the upcoming discussions on the unmet medical needs as part of the EU Pharma Strategy revision, we would like the legislators to pay special attention to unintended consequences of defining unmet medical needs. So in order to treat liver cancer successfully, similar to other cancer types, it has to be diagnosed at an early stage, and this is not obviously happening for liver cancer now. So I will not speak about the importance of liver cancer prevention, as this will be discussed in the second panel, but just want to highlight that we feel there is a need for more research to be done to understand what are the cost effectiveness of different prevention strategies. Then for the development of new simple diagnostic tools for early detection of liver cancer to increase the screening window as described by Professor Sangro, and also artificial intelligence tools to predict the risk of developing liver cancer in patients with liver disease. From the presentation of Professor Deckerville, we really welcome the news that there are now more treatment options for the treatment of liver cancer patients, but still we would like more research to be done, but also to understand what are the best treatment strategies, what is the best sequence of treatment in order to be able to prolong the survival for liver cancer patients that is currently really low. Like most digestive cancers, liver cancer is also an under-researched areas, and with the increasing burden, we really need urgently to address this. So from our point of view, more research is needed and more funding, but it is really a shame when there is funding available and we don't use the funds, as it was shown by Professor Jepsen. So just to finish up, I strongly believe that we should not speak about liver cancer only today or during the month in October. I also think that we should be discussing jointly this burning issue every single day. So thank you, Ola, and over to you.
Right. Thank you very much, Zorana. I think we have a little bit of time left for our question and answer session. And we have a question from the audience we would like to address first. It's from Camilio, and he's asking, and I would like all the panelists to listen to the question and one of them to volunteer to answer to it. So the question is, from the patient's point of view, what can patients with advanced hepatocarcinoma who have failed first-line treatment expect from the health system in European countries that have not financed already authorized drugs? So it's a very complicated question. I wish we would have a commission representative or institutional representative who could have answered that question. Unfortunately, that was not able to secure their presence. But nevertheless, would some of the panelists like to answer this question, try answering it? What would be the ideal outcome?
I can maybe start. So I think, yeah, the good or the better outcomes that we see in HCC with systemic treatments in part is due to the fact that we have multiple options that we can sequence. The problem from a scientific point of view is that the drugs that we give after the standard first line option right now, for example, in Europe, these drugs do not have really good data behind them to be used in subsequent, so second or third line. And this is, of course, something that several countries may use and say, well, okay, we cannot make this drug available in this specific situation because the scientific data is just not there. We know that these drugs are active in HCC. We think that they're active in second line after the new first line standard of care, but we're not 100% sure. So from a scientific point of view, what we need is more trials, more studies in second line. So we can convince, of course, healthcare providers that they should also offer these drugs to the patient in Europe.
If I can add, I fully agree with what has been said. Beyond the scientific or the things that we can do from a scientific perspective, there are also things that we physicians, hand by hand with patients, can do to make sure that the treatments that are effective, as Jorina has certainly pointed out, are made available, and that is making the legislators and the regulators at each individual country feel that there's an absolute inequity to allow patients to access any form of treatment based on arguments that are not made public. And I can just speak for what happens in Spain, where, contrary to, for instance, what happens in the UK, the discussions about why and why not reimbursing one drug or another in specific situations are not publicly available. This is something that physicians and patients can work together to try to solve in the future.
Okay, thank you very much. Would Professor Jepsen would like to add something, or?
No, not really. I think I agree with what the Sangro and Decavel have said. So no, thank you. I have nothing to add, really.
Okay, I think we have a little bit of time left before our next panel. And I would like to ask really the whole panel. I really like what you mentioned, that if we put our minds and money into it, we can crack it in a way. It can be done. So if you had the decision power, where to put money into, which kind of research, what would that be for each of the panelists?
Well, I can start. If there is enough money, of course, there are many things you can do. I personally believe that now that we have, as Dr. Decavel has pointed out, better treatment options, it is the time for early diagnosis and early intervention, because if these treatments are applied only in the late stages, the chances that we may change mortality are lower. So early diagnosis and early intervention is absolutely a must. And just 1 second to say that medical research does not only apply for understanding the mechanisms of why a tumor appears and how it can be treated. I think there is a lot of research that needs to be done into stigma. Why is liver cancer stigmatized? And what are the reasons for that? And because only by knowing the reasons we can change the stigma. And similarly for access to care. What are the reasons that explain the differences in access to care in different countries? Only if we do research, we will be able to be effective in that regard.
Okay, thank you.
And if I might add, I agree that money would be very well spent on improving our ability to diagnose liver cancer early. It's really so very important that we can diagnose liver cancer early. And I think we as clinicians think that really we need better screening tools. I mean, if we could have some like a screening tool that requires just a blood sample instead of an ultrasound examination, that would really be extremely helpful. And I also think it would be helpful if we were better at risk stratifying our patients with liver cirrhosis, so that some relatively high-risk patient could have more frequent screening, whilst some with a relatively low risk of liver cancer would require less intensive screening. I think this is the way the field is moving, but it's moving very slowly, I think. So I think we as clinicians would love to see more research in that field.
Great, thank you very much. And Professor Dekeva, do you have a last famous words?
Very short. So I completely agree. And if I have to put one on number one to invest in, it would be that early detection. Because we need a huge collaborative effort with a huge number of samples that we can train a certain test and then validate as well. And of course, a good follow-up of all these patients that would participate. So that's a huge effort. But if there would be money to do so, then this would be the first way to go. Just to say something else as well, I think some kind of neglected population is a population with a less well-functioning liver. If we see that all trials are now directed to patients with good liver function, but if we go into the clinic, we very often see patients that do not fit the inclusion criteria of the current trials. And we have now less toxic, more potent drugs. And I'd also like to see whether they can be of added value in patients with slightly decompensated liver cirrhosis, for example.
Lovely.
Well, Alexandra, if I may add,
yes.
I think you know that as I completely agree with the three professors, but also I think that we are not using very well the data. The data is fragmented. And that, you know, there is probably already a lot of, potentially we could gain a lot of knowledge just from having this data and having better data. So, you know, from pharmaceutical industry, from different research centers, from different registries. And I definitely agree that European liver registry, you know, is a must. So from this perspective, and then obviously from patient perspective, this is not for funding, but from a patient perspective, I believe there is a great really need for patients and their families to be supported from the very beginning as soon as they're diagnosed, because this is really a huge shock and, you know, something that they have to face, and this is not currently happening.
Okay, thank you to all the panelists. And we're going to move on actually to the topic now that you have already touched upon in your speech, Professor Sangro, to prevention. And I think all of you have mentioned how important prevention is. So would like to highlight in this section why and how public health policies at the EU level, but also at the national and local level, should tackle the risk factors for cancer. I think the why question you've all answered in your presentations, but maybe we would focus a little bit more now going into detail on how. And I would like to invite our next panelist, who is Professor Sven Frank and Professor Schattenberg and Marco Koreniak. I understand, if I understand correctly, please correct me if I'm wrong, that you will have a joint presentation somehow.
Yes.
Okay, so I'll leave the floor to you then. Thank you.
Okay, so thank you very much for inviting us. My name is Jörn Schattenberg, and as just mentioned by you, we have prepared a presentation that we're going to be presenting together, my colleagues Sven Franke and Marco Koreniak, and I think this is really important based on what we've just learned to be discussed intensively how we can optimize the prevention. And I think we have enough room for a discussion after our presentation to really move this forward. I'm just going to start out by very quickly recapping and giving you my view on the increasing burden of liver disease and HCC. This is something that's been addressed by the previous speakers. Here you can see the WHO list of causes of death and premature loss of life, and actually cirrhotic liver and liver cancer, in particular in males, are high on the list here. And I think that came out in the previous presentations already. If you look at the map at the estimated incidence of HCC attributable, for example, to non-alcoholic fatty liver disease, you're going to get a very different picture from what an HCC map related to chronic viral hepatitis normally looks. And you all of a sudden have an overrepresentation of Europe, US, and Middle East countries here. And I've put in representative imaging as we use it today to diagnose that cancer in a patient that is obese, that doesn't have liver cirrhosis, but has big cancer. And it speaks to the currently, in my eyes, not really met need, as also highlighted by our previous speakers, to identify these patients, even if they're not cirrhotic, based on certain aspects of their disease. And I think, Sven, I'm going to hand it over to you to discuss a little bit why we think there are good ways to prevent this, and I'll be happy to advance the slides on your behalf.
Yeah, thank you very much. I think one of the very important things is, and I also refer to Professor Sangro's slide on the causes of liver disease, and 3 out of the 4 that were in green because they were preventable and or treatable diseases, is that liver cancer, almost, not in all patients, but there's in the vast majority of the patients, there's an underlying chronic liver disease, chronic damage to the liver, chronic inflammation to the liver. And what is important to know is that much of that is preventable, or if it's already there, it's amenable to improvement. The liver is a very robust organ. You need some continuous important pressure on the liver to really have progressive liver disease, more and more scar tissue, and evolve to a liver cirrhosis, because the liver has a lot of mechanisms that help the liver to repair, to fight against that damage. And so if you have, on the one hand, drivers of the disease, but you also have repair mechanisms, it means that somewhere there is an imbalance. And if you are capable of working on the drivers of the disease, or even prevent those drivers of the disease, and you restore the balance, then repair mechanisms can take over, and your liver will even get better, which is not the case for many of the other organs. If some organs are heavily damaged, like your heart muscle, for example, you can have some mechanisms of the heart try to cope with that, but you will never restore a perfectly normal heart muscle again. That's not true for the liver. Even if you have quite advanced liver disease and a lot of scar tissue, you can have an improvement of the liver, provided that you take away what is driving that liver disease. And what are the most important causes? As I said, nicely mentioned by Professor Sangro, we have viral liver diseases, but some of them can be treated. We have very efficacious medication to treat these viruses, or to suppress them at least. Professor Schattenberg mentioned non-alcoholic fatty liver disease. It's the liver fat and damage that occurs in people living with overweight and obesity and diabetes. There is also the important role, of course, of from alcohol as a cause of liver disease. These are all elements that can be worked on, both prevention, or if you have already the liver disease, if on these driving forces of the disease we can improve, then you will liver disease help to regress. Regression of an existing liver disease does not necessarily mean that your risk of liver cancer completely disappears. It can still be more elevated compared than somebody who never had any liver problem. But it can substantially improve. So there's a lot that we can do in prevention, or if you have a liver disease, in treatment, to make the liver get better and substantially reduce the risk of developing not only cirrhosis and all the consequences of that, but especially also the risk of developing a liver cancer. So it's very important to restore that balance. You can show the next slide if you please. Yeah. So this also shows you again, you have, of course, the classical progression of a liver disease. This is the example again of that fatty liver disease in the context of problems of overweight and obesity and diabetes. You have different stages of the disease, but you can go back. It's reversible, not always completely reversible, but it is at least in part reversible. So there's a lot that we can do to drive the arrow not to the right, but to the left, and so also reduce the risk of developing liver cancer. Yes, next slide, please, Johan. So, as I said, and as Professor Sangro said, again, with his 3 out of 4 diseases in green, alcohol, metabolic factors are very important, and there's a lot that you can do, and there's a lot that we need to support people to do about lifestyle. It's of course not that easy. It has to do with some genetic background. Some people are more vulnerable for the negative consequences of that than other people. It has a lot to do with socioeconomic circumstances, with cultural differences, but there is a lot that can be done. And with the help of patients and a whole group of physicians of all different specialties, we have composed this as a small contribution. There is way more that needs to be done on a societal level and on the level of policymakers, but this is a contribution of the scientific world with the patients together to provide some guidance, some help on what we can do to prevent, or if the disease is already there, to improve on this disease, and as I said, to try to prevent on the long run the deleterious outcomes of this. And I hand it back over to you, Professor Schattenberg, for the rest of the presentation.
Yes, thank you, Sven. And I think this is a very nice example on how the field actually can in certain areas move together, because as you said, the patient guideline that you published here is really the work of different groups that have joined forces to make a clear recommendation or a strong recommendation on how to venture in one way and improve prevention. I'd like to follow up and say that actually the European Association for the Study of Liver, EASL, which I, like Peter Jepsen, represent as part of the Policy and the Public Health Committee here, has partnered with Lancet, and there was the EASL Lancet Commission brought forward that has very strongly pointed out that protecting the next generation of Europeans against liver disease, complications of premature mortalities, has a number of points that we can address to make a future life more liver healthy. And of course, the points that were raised are that we have to recognize and remind and educate people that we're living in an environment that fosters and supports liver unhealthy behaviors. Now, those are self-made choices, but I think as in part, they're self-made choices, but I think as a community overall, we have to be very careful that we protect vulnerable populations from marketing aspects that do potentially influence these self-made choices. Namely, we have marketing of alcohol and ultra-processed foods in the EU, high sugar containing foods, drinks to children, which are very closely linked to illness, liver illness, but also metabolic illness. And as such, with an epidemic rise of metabolic diseases, of alcohol-inflicted liver injury, these reminders are very important overall for the field and the society. And this is something where we need to advocate that liver health and metabolic health can be improved by avoiding these type of environmental factors. We have to promote the access to healthy diets and physical activity, Now, this could mean that you have an extra urban green space in the area that you live, safe housing, safe environments, an environment where you are readily can go to the street and exercise to lead an active and physically active life, which at many levels going to improve health outcomes, in particular also improve liver health outcomes. And that advocacy, I think, is something that's needed. We have to educate fellow physicians, and that's point 3, that are not so used to consider liver health as an important aspect. So there's a lot of patients that have well-defined risk factors for the development of liver disease. In the realm of chronic viral hepatitis, that is, of course, substance dependency, treating physicians, but in the realm of non-alcoholic fatty liver disease, as was mentioned previously, that's physicians that treat patients living with type 2 diabetes. And obesity and type 2 diabetes are 2 major risk factors for hepatocellular carcinoma, and we have to expand the knowledge on prevention for liver disease outside of a very restricted liver field. We have to really open this up and have physicians support the concept that a healthy liver will also support, overall mortality and decrease the incidence of cancer here. And for that, clearly multi-stakeholder educational programs are required. And the good thing is, among other professional associations, and I'd like to highlight the role of EASL here again, but also the European Diabetes Association, we've actually come forward with guidelines for physicians and patients to define who should be screened for metabolic unhealthy liver or non-alcoholic fatty liver disease. And you can see some examples here. We have intensively discussed in the field what should be used, why it should be used, and how it should be used. And I think those are ongoing discussions. There's a lot of research in the field of non-invasive tests, a very important aspect. So we're developing and have validated markers that are fit for use in clinics today. And we will continue to produce biomarkers that are required to identify those patients. I think this is an area where more research is needed and funding. That was mentioned in the beginning, the first discussion already, but I think we have tools that can be refined further to actually meet that task, as I just showed you, to identify patients with unhealthy livers. So in the guidelines, there's emerging recommendations on how to do that. This is a slide that shows you the results of a research study. We've actually performed in Germany with payers. And without going into much detail, it was a study that showed very pragmatically that at the primary care level, which is the Hausarzt in Germany, you can use blood-based tests that are today available. You can identify patients at risk for liver disease and refer them in a subsequent referral pathway to a secondary Facharzt specialist, or even a Leberzentrum, which is the specialist high-end tertiary care medical center. And without going into the details of this study, the setup was good. I'd like to show or highlight that even in patients with suspected liver disease, in this setting, we've lost a lot of patients that did not show up for their subsequent recommended exams, even when they were identified with liver disease. What does that mean? And I think from a scientific level, you can discuss at multiple levels how that result should be interpreted. But I think it needs that we need to do a lot of education on all levels to make sure that there's a linkage to care for these patients, that we do provide prevention and education. And for that, again, we need to develop models of care in that area that go beyond one specialty promoting liver health, which is mostly hepatologists. At this time, we do not have enough hepatologists to tackle all the high number of diseases. And as such, there are emerging recommendations on what should be done, who should do it, how we have to do it, and where it should be done. And it can be very different in different systems. I think at this point, funding is needed to really support these type of models of care or implementation of patient referral pathways that would then also allow for prevention and preventive measures, of course. We're almost at the end of the pre-paired talks, and I'd like to also hand it over to Marco from ALPA before we're finishing. But my last thought that I'd like to share with you for the benefits of screening of liver disease, and it's today not good practice to do this at all levels, is that we have a disease that's highly prevalent, and we have subgroups well defined. We have testing strategies that are being developed. There might be refinement needed, but in general, we're talking about a preventable disease. There's a huge opportunity for prevention, but it's not met at the level of implementation at all spheres. And if you look at the WHO screening programs recommendations, balancing the harms and benefits of screening programs, I think in the context of the discussion we just had, there's a clear pro liver disease at this point. And this is our summary slide. Marco, I'd like to talk on this briefly, but then just let it sit and give your perspective afterwards. I think both Professor Franke and I made a strong case, or I aimed for saying that we have a preventable and reversible disease here when looking from the liver side. Stigma and unawareness is going to be discussed in a minute. We need screening programs that are refinanced and used to support the patients. And I think there's a big opportunity for prevention, early diagnosis, improvement of metabolic health, which is going to benefit the liver, but also other organs, and then reduce the long-term deleterious consequences of liver cancer. Because, as previous speakers said, the liver is an organ that responds slowly. There's a lot of time, but we shouldn't let the opportunity pass to be preventive here. And with that, Marco, I'll hand it over to you to round up our presentation.
So thank you very much, Professor Schattenberg. And first of all, so my name is Marco. I'm the president of European Liver Patient Association. And I need to thank first for Professor Franke and Professor Schattenberg, because we developed this together. So we were looking at the problems that the liver patients face, and we were thinking about the prevention and what to do. So I think that these key considerations that are here are speaking for themselves. So many liver diseases preventable and reversible. This is something that all decision makers should hear, because this is something where we should work together. Of course, we didn't address stigma so much, but this is something for maybe next discussion or next panels where we will already have something on the table. But regardless of the funding that is available, we can also do things now like raising awareness and educating physicians, which we are already doing. So the medical field is already doing what it can, and also from the patient perspective, we are trying to raise the awareness. So there are several points that needs to be addressed in the term of prevention, and that were mentioned today. And we also think together that this is a great opportunity to develop new models of care, try to repeat models of care from one country where they're already working very well to another country. And I will just conclude with description. So at ALPA, we will do whatever we can to change this landscape, because liver patients who are diagnosed with liver cancer are usually old. So we need to change this shift, and we need to try to catch them earlier. Because if you have an early diagnosis of anything, also liver cancer, you have better possibilities what to do. You have possibilities what to do. If you diagnose something very late, these possibilities are very, very narrow. So we have a field where much can be done, and we can focus on prevention and early detection of changes in the liver. And we are thanks also to DICE that we are working in this way forward. So thank you very much.
Thank you very much, Marco. And I think it's very timely what you just said, because we heard in your presentations that if you catch a liver patient early enough, you avoid a liver cancer patient. And we have a pleasure to have liver patient with us, and we're going to have a few words from them now, from the representatives. We're going to start with Dr. Casanova, who is the leader of the scientific committee at ALPA. Unmute yourself. You stop and unmute yourself.
Teresa, can you please unmute yourself?
Sorry for that. I said
I'm
that,
sorry, we have to start from the beginning.
yeah. We have had a lot of developments and advances in liver cancer, but in our opinion, they need to be better communicated to policymakers and advocacy groups to be implemented throughout the patient pathways and citizens. Also, when you ask about to put money, our opinion is that it would be urgent to put money in primary care because liver cancer has symptoms only at advanced stage, and it is crucial to have an early diagnosis and even prevention. We must implement screening programs at a national level and in each country. A multidisciplinary team must be mandatory since the very beginning.
Okay, thank you.
Thank you.
And as I understand, there's another cancer representative with us who will take the floor now. Sorry, liver patient representative, I'm so sorry.
Thank you very much. I'm Julio Buhmann. I'm Vice President of ELPA. And I wanted to remark what Dr. Casanova said about multidisciplinary team, that it has to be mandatory, but from the beginning, from the diagnosis. And health literacy is a critical empowerment strategy to increase people's control over their health. The ability to seek out information and to take responsibility. Health literacy has been shown to correlate directly without outcomes. And in medicine, language matters, mainly because it may be related to stigma. Thank you very much.
Could we hear from Tove now?
I can join you first till Tove is reading some.
Okay, thank you, Milan. So now we're going to hear from
No
Milan.
problem. Thank you very much. It's my pleasure to be today with all of the distinguished speakers, policy decision makers, and scientific researchers, which make such a big contribution to, especially to us, like patients and the patients who are listening, to understand what kind of gaps, challenges we have it in the moment. But what is important for us, like a liver patient representatives, that our hope, our beliefs are that nobody, like a patient, should be out of the frame or should be left behind. And in our opinion, I must be honest that like a patient representative, advocate or lobbying guy, we need to have something that is going to be for the countries some interesting topics we need to change. One of that is that implementation of different kind of programs, for example, for elimination of viral hepatitis and clear programs to address liver cancer. Considering hepatitis C, there is no excellent treatment. There is an excellent treatment. Hepatitis B is more complicated, but there is a preventive vaccine. Also should not forget Delta, because the treatment was approved for the first time. What is very important for us like a patient is to reduce the prevalence of liver diseases. The risk factors will require a whole of society approach. Even communication can help raise different kind of awareness of the of liver cancer among the general public. However, information must be easy to understand, but reliable and scientific. Patients need to have access to early diagnosis and screening on equitable basis. Healthcare must reach everybody. But what is most important for us like a patient is that we notice that in Europe, on the European ground, we are missing not just the funding which you mentioned, but also we are missing a different kind of programs who are just health programs. I'm speaking generally, not just for liver diseases. This is very important that like patient community and the scientific community in the future, we need to raise also another questions which will connect specifically health to be a topic among the policy decision makers in Europe. This is number one. And the second thing is that the liver disease need to change a little bit approach, especially to avoid the margins of the societies which exist in a lot of countries among Europe.
Thank you very much. And I think now we have a last but not least intervention from Tove Frisch.
Yes, hello, Tove Frisch, ELPA and Sweden. I see now that I had planned to say much more than I have the time to speak. So we all agree on the screening policies we should have in Europe. We know that every country now individually has to decide, and it is not working well. So even a rich country like Sweden doesn't have a general screening policy on liver patients or liver diseases. So we need more scientific and political and economic efforts for that respect. I would just like to tell you two examples here instead. I was recently at an international convent and about transplantation. And there was lots and lots of specialists from lots and lots of countries. And even though liver patients or liver transplants are the second most common reason for transplants, nobody, not even specialists in liver, brought up liver cancer. It was all kidney, which is normal, it is the biggest, and heart and lung. And nobody talked about liver and liver cancer. And it is a very forgotten disease. So I think we need to do lots of efforts there to lift up this very important and terrible disease. And that is one thing. The other is a friend of mine who had lots of signs of NAFLD. He went to his doctor and said he wanted to examine that. The doctor just laughed and said, no, you don't have fatty liver. You don't have hepatitis. So that was the answer. So there is a lot of information needed, even in a so to speak, developed country like Sweden. And then about stigma, we have mentioned stigma a little bit. And stigma, of course, is in a lot of families and social cultural environments and so on. But there are also, I will just mention one remedy, which I think is forgotten a little bit, and that is apart from all the social efforts made by politicians and organizations and so on, there is also a personal and individual effort needed, you can say. And I think that the personal courage to talk about the disease and to tell other people that there is no more shame or personal guilt, with liver cancer or liver conditions as it is for other conditions, such as obesity or lung cancer or whatever. So, and I also think that it is possible for famous people who can talk about it will also make a difference. And then, of course, we need all the social, the other efforts that we have already mentioned. As for the families, I am thinking, family support. I think it's very important to, of course, strengthening the social services, but also make sure that there are health centers close to the people. We have to get into the cottages, so to speak. And we have to find the people who are not used to seeking healthcare. And I think it was Mr. Jepsen who was talking about this digital center, which is of course very good. But my experience is that a lot of patients with liver conditions and patients overall, you know, they are not always so keen on looking at internet or even having the knowledge how to do so, or even how to understand the information they get. So I think we also need to combine it with face-to-face meetings and possibilities for patients to come to centers very close to where they live. So we have to seek them, and we have to make sure more people are diagnosed. Mr. Schattenberg also said something very important about the marketing of alcohol and so on. This is also a very big field that we have to look into. Thank you very much.
Thank you so much. I think we covered so much within the last panel. We had, you know, things from implementation of guidelines and great work done by EASL when the doctors took it kind of in their own hands to develop recommendations and guidelines that then can be implemented. We talked about, you know, the research and education. So I think we have a few minutes left before we pass it on to our guest of honor, in a way, our MEP, who is kindly joining us now. And I think it's because we have him online. I would like to hear from the panelists from this session about prevention. If you had one policy that you would say, we have a European Beating Cancer Plan, we have a pharma strategy, we have loads of policies going on. If you have one policy you would say that the MEP should vote forward or for this law, what would that be? And maybe we'll start with Dr. Sven Frank, Professor Sven Frank.
There are, of course, many things on the bucket list, but if there is one, I think there should be a huge investment in patient empowerment and awareness about what liver disease and what a healthy life is, and to make sure that there is, in terms of facilities, to be active, to have support for nutritional counseling and so on, to make sure that the empowerment is there and the support is there to be really on the preventive side and not just on the curative side.
Thank you. And now maybe Professor Schattenberg.
Yeah, thank you. I'll cut my wish list down to saying that I think the EU and the member states need to be empowered to implement multi-stakeholder care for patients with metabolic disease, in particular metabolic liver disease. It came up that this is one consequence here. We have to be able to work across one discipline to identify these patients to really improve the survival. And that means providing healthcare systems with guidance on how these patients can be managed, identified, and counseled for prevention.
Okay, thank you. And Marco, is there one word you would like to add? If you could make policies, what would that be?
So thank you very much. I think we have all the tools that we need to try to get like early detection of liver diseases, because as a patient, if you get a diagnosis very early, you have several possibilities what to do. Of course, I would go into that, and I would just echo what Professor Frank and Professor Schattenberg has said. These are also an important steps that needs to be implemented as soon as possible. Not yesterday, not today, but you know, like 3 days before today.
Thank you. And I can see that our chair of DICE as well, and a former MEP who used to do policies, could tell us what she would do if she had the power to do policies. Thank you, Leva.
Thank you. What for me is important, that we know what the importance is of centers of hepatology and specialized centers, and that Europe will enforce this, and also that those centers in the different countries will work together and learn from each other, because there is so much knowledge. So give the knowledge to each other so we make each other richer in knowledge. Thank you.
Thank you very much. I think that is, you know, kind of really brings us to the next, our next panelist, who will do the closing remarks for us. So if I could ask MEP Sako Office to connect. Oh yes, MEP is himself online. So I'll just give the floor to you, and I hope you were able to listen to some of the discussions we had today, and what you would like to add from your side to us, and how you would like to take it further.
So good afternoon, everybody. I'm really happy to be with you and support this important discussion on liver cancer to optimize European response so that no patient is left behind. I would like to thank first all our panelists for their input, and Digestive Cancers Europe and the European Liver Patient Associations, who have made their mission to improve the outcomes and quality of life for liver cancer patients across Europe for organizing this whole event. I think we are at a crossroads in our fight against liver cancer in Europe. A fight we are currently unfortunately losing, as Europe bears the largest burden of liver disease in the world, one that is expected to grow. So we have heard from our distinguished speakers of the limitations and obstacles facing our understanding of this disease and its prevention. Of course, I was able to hear a lot of what was said, not everybody, but I think but I can make a few points here. So first, what I would like to emphasize, of course, is that healthcare is primarily a national competence. We all know that, especially organizing and financing of healthcare systems. So we cannot unify legally how different healthcare systems deal with liver cancer. What we can, however, is to use the tools that we have at our disposal, like financial tools, for instance, to support and complement national policies. And here, obviously, we have Europe's Beating Cancer Plan, which provides for larger investments into early diagnosis and prevention, which is very important. That's one of the highlights. I think maybe the strongest part of Europe's Beating Cancer Plan is precisely the part on early detection and prevention. Of course, we have funding available from EU for Health program for that, but I would also like to emphasize that the largest source of funding for healthcare from EU budget is actually the cohesion policy. And it was mentioned here that one of the big problems is diversity. So different situations in different member states in terms of healthcare provision and the healthcare coverage and the way of tackling the liver cancer. And precisely cohesion policy's objective is to reduce these differences, these inequalities. So we spent around 25 billion euros in the previous budgetary period from cohesion policy and healthcare. And so this is definitely a big source of funding which we can use also for prevention and early diagnosis. But also one thing that was mentioned in the last intervention, and that is the infrastructure. So cohesion policy funding can be used to build infrastructure, to buy equipment, and to really also improve the treatment of liver cancer and to make it more equal in different member states. Of course, we also have the Recovery and Resilience Facility, which is also one major source of funding, which also provides for reforms which member states have to make. And here also there is a good possibility to fund a lot of things which are also related to liver cancer. When you speak of regulatory part on prevention, of course, there is the issue of alcohol, marketing of alcohol and taxation of that. We had a lot of discussions in the BECA committee on that. This was one of the major points of contention between different MEPs. So this will be one of the topics which will be very important in the future discussions that the Parliament will make, because this is also one area where EU has concrete power to act. But how this will develop in the end, we will see. It's not really clear cut at this moment. So as an MEP, I will continue to support all the initiatives which aim at providing more research funding as well. So Horizon is very important. Now we have the cancer mission in the new Horizon program, and also to optimize the knowledge of liver cancer, but also all of the things that I mentioned related to early detection and also prevention. To optimize prevention, apart from things which I mentioned, we need to also improve implementation of prevention practices, other prevention practices like universal vaccination against hepatitis B virus, universal treatment of hepatitis C virus for all HCV infected patients, but also encourage the development of AI tools to improve the risk prediction in patients with liver disease. And I believe that all stakeholders across Europe must work together to make sure that best practices are implemented at every stage. This is why these kinds of discussions and exchanges are important, so that we can have that we can learn from you, and we can get inputs from you, which are very important when we make policies. When we speak of the current legislation that is related to liver cancer and healthcare in general in the coming months, the one that is currently on the table, we have the Commission proposal that is a regulation in European health data space. the aim of which is to create one European space where we could use health data without obstacles, meaning that we have interoperability of data, same standards as protocols, that we can exchange data in different member states, which is important for research, for innovation, for clinical studies, but also for concrete treatment. For instance, when we speak of chronic diseases like the ones related to liver, for instance, if you're going for a trip to another member state, or you are studying for a semester in another member state, it is important that when you need to do routine checkups and see doctors in that member state, outside of the member state in which you normally live, then it's important that these doctors have access to this data. And for this reason, health data space is also very important. Also, secondary use of data is very important. So as I mentioned, for research, innovation, clinical studies, etc. I'm glad that I have been appointed the European Parliament's rapporteur on this file, and we will try to do our best to have this file in the first half of next year enacted, so that we can really make optimal use of data that we cannot use now. Apart from that, the revision of pharma legislation is coming up. We're waiting for the Commission proposal. Also, the rules on things related to prevention, like alcohol. We depend on the Commission to make a proposal, so the Parliament cannot make legislative proposals on its own. So we will see how this will look like. But definitely, in my work on these files, I will do whatever I can to help liver patients to engage with stakeholders, to get your inputs and your suggestions on these different files, and because I think that we can really use all of the things that are being done now on European level to make a difference, to have better prevention, better diagnosis, but also better treatment and better quality of life for liver cancer patients. Now we have, so healthcare has traditionally, this is last thing and then I'm finished, healthcare has traditionally been a marginal topic in the Brussels bubble, I have to say. This has changed because of the COVID-19 pandemic and Europe's Beating Cancer Plan, but we are losing this momentum pretty fast. New topics are coming up, newer topics are being put in the focus, like war in Ukraine, energy, things like that. So we need to maintain this momentum as long as possible to actually make differences and to have much better health protection than we have now. So, but to do this, we have to keep the focus and emphasis on healthcare within European institutions, and this is why your engagement is so important. So thank you for. So in the end, I would like to thank you for your attendance and participation in the discussion, and let us turn the words that were said today in the action, in concrete action. Thank you very much.
Thank you very much. And I think that was a perfect ending to a very good meeting. So for all our participants online, you can follow ourselves, DICE and ELPA on social media if you want to hear from us again and look at our events. We will definitely be in touch with you, Mr. Sokol, regarding the European health data space, regarding the pharma strategy and other issues. So thank you for your offer to take it forward with us. And I wish you all a pleasant afternoon. Thank you.